In this video, we're going to discuss patient care reports. Now, the patient care report here at Guardian Elite Medical Services is a 2-page form. It's a front and back. It is not carbon copy, so it's just a front and back page that we retain. See, this is what the front looks like, where you go ahead and put all your call information, patient history, chief complaint, vital signs, and everything else. And the back is dedicated just for the narrative, along with signatures and attachments that go with the patient care report. So before we get into how to fill out a patient care report, let's talk about why a patient care report is important. So a patient care report is used to document all patient care activities. It is used when a patient has a significant medical or trauma complaint and they either refuse medical assistance or advice, or they are transported to the hospital by Guardian Elite Medical Services or another ambulance service. So just some general guidelines for our patient care reports. So first of all, this form is only to be filled out by Guardian Elite Medical Services employees. Now, there are times where we do work with other practitioners, or we do work with other people who are not employees of ours, and they want to fill out our forms. If that's the case, don't create an issue, don't make it a big deal. Give them a form, let them fill it out, but we need you as the employee to go ahead and fill out your own patient care report, and then go ahead and submit their patient care report with your patient care report. In addition, patient care reports are only to be filled out in blue or black ink. Pencils not allowed, funny colors like red, pink, purple, those are not allowed. The only 2 colors allowed on the patient care report are going to be blue and black ink. And these are to be filled out as soon as possible after a call. Now, the health district actually has a regulation inside its regulation manual that I believe says patient care reports have to be filled out within 4 hours. However, this often is used more for transporting agencies. However, with us here at Guardian, we just need to get them filled out as soon as possible, just to create that back, or to simplify, or not so much simplify, but to alleviate a backlog of reports that might occur during a shift. So now we're going to go ahead and get into the actual nitty-gritty of how to fill out this form. So at the very top right-hand corner, you will see that there is an incident number in gray. This is to be left blank. There is no reason why you should have to fill this form out unless you are told to do so. Correction, no reason to fill out this field unless you are told to do so. So the incident number is going to be left blank. Going down on the upper left-hand side, we have the call information. So the call information is going to contain the date of the call. The date of the call is basically when you ran the call, what date the call was received. Below that, you have a call sign. This is going to be referred to as your radio call sign for your shift, and this will vary by event. For example, if you're at the Las Vegas Convention Center, you might go by whatever medic number your room is. Or if you're assigned to an ambulance, it would be your ambulance number. Or if you are not assigned a call sign, or you don't know, you can just use a general call sign for medic. But it's call sign is however you go by on the radio. And then we have the event name. The event name is going to be the specific individual name of the event. Meaning, Consumer Electronics Show, or Further Future, or SHOT Show, or whatever the name of that event is, that goes in this field. Below the event name is the venue. Now, the venue is different than the event name. For example, the Consumer Electronics Show is the event name. It's held inside the Las Vegas Convention Center. SHOT Show is another event that is a name of an event that is held at the Sands Convention Center. So please make sure that when you're documenting these, the event name and venue name are different. Venues hold events, and each event has an individual name. Call location. This is going to be a specific location of where the patient was located. We need to be as specific as possible. Might be a poll number, a booth name or number, a hall name, cross streets, or any specific identifying information of the call location. Now, I'm going to give you guys an example. So the event name would be, let's say, CES. The venue would be the convention center, and the call location might be pole 123 or booth number XYZ. It's important that, especially with call location, that we narrow down specifically where we see these patients. Another example that we see a lot are car accidents that we roll upon. This would be like the intersection in which the car accident took place. Moving on, so times. So times document what time we did certain actions. Okay, we should have our dispatch time, patient contact time, and available time on every patient care report. Now, the dispatch time is going to be the call that the time is received. The patient contact is the time that patient contact was made. And then the 2 first aid and transport calls. So this is going to be the time that we leave the scene with the patient to go to a first aid room. Or this can also be the time that an ambulance was called. And then the ambulance arrival time is going to be that the time the ambulance arrives, and the available time is the time that you clear from the call. If a time does not apply, for example, an ambulance was not called, just go ahead and document NA in that field. Please note that times are required on all calls. You cannot leave those 3 fields blank. We have to document times on all calls. Call disposition. This is going to be what happens to the patient after they leave our care. This must be documented on all patient care reports. Please note you are only going to check one high-level box. So that means either 1, 2, 3, 4, 5, and 6 are going to be checked. Do not mark patient on scene, do not mark patient released on scene and then patient AMA'd. Those are 2 different things that are documented. So let's go ahead and break down each one. So a patient release on scene. So a patient release on scene occurs where the EMS provider and a fully competent patient, meaning that they're ANO times 4, GCS 15, able to follow simple commands, with a relatively minor medical or trauma complaint concur that additional treatment and ambulance transport are not necessary. Examples might include patients with traumatic injury and does not meet the trauma triage field criteria, patients with a minor medical complaint who have an articulated plan to receive follow-up care in an emergency room, urgent care, or primary care physician, and patients who have not received any invasive treatments in the field, including intravenous medications. If any advice is given to the patient and they refuse that advice, then we want to go ahead and go down the AMA route. So what would be a candidate that would be a release on scene? Let's say somebody that comes in with a small infection and you go ahead, you do a full assessment, you get vital signs, you're documenting, and you say, hey, I recommend that you receive treatment in urgent care, and the patient says, great, where do I go? We can go ahead and release that patient. All right, and then just to clarify, so any patient who receives invasive procedures, i.e. intravenous access or medications listed on the SNHD EMS formulary, are not eligible for a release on scene. We must AMA these individuals. So, in AMA, and we have specific AMA documentation, which we have a video that you can go ahead and watch. So we're just going to just briefly discuss AMA documentation as it pertains to disposition. So an AMA occurs when a patient is given some kind of medical advice, either take an ambulance to the hospital, get stitches into urgent care, anything that you recommend, and they say, you know what, thanks, but no thanks, I'm fine, don't want to do it. We need to go ahead and fill out an AMA form. So we go ahead and we need to fill the AMA form out. We need to document that they signed AMA, and then we also need to go ahead and document their intentions. So we're going to go ahead and check 2 boxes for an AMA. For example, the patient's going to AMA and return to the event, or they're going to AMA and seek treatment in a medical facility, or AMA and they intend to go to a hospital a hotel or home, or we just simply don't know. And then on the back of the form, or the back of the PCR, we need to document all medical recommendations that were advised. For example, if an ambulance was recommended and the patient refuses ambulance transport, then we need to document on the back of the PCR that the patient refused ambulance transport. Remember, if an AMA form is filled out, then you must complete a patient care report. I will say this again, if an AMA form is filled out, you must complete a patient care report. So we have just a few scenarios here to go over. So this is discussing whether we're going to AMA or release on scene. So you have a 25-year-old male, comes to your first aid room, he's got a laceration on the finger, it's about 2 inches long and looks like it needs stitches. The patient is advised to go to a physician and is given a list of clinics, but the patient states he wants to go back to work and will not see a physician. what would we do? Is this a release on scene or is this an AMA, and why? So this would be a AMA, or against medical advice, because the patient is refusing to follow the advice and seek treatment from a physician, which means that we have to fill out the AMA and the patient care report. And then what should happen, or what should be documented on the narrative portion, basically what happened to the patient was advised to seek treatment, the patient refused, and the patient said they were going back to work. All right, number 2. So a 65-year-old female tripped and fell. The patient has a minor abrasion with some swelling on the left knee. The abrasion is cleaned and bandaged and given an ice pack. Excuse me. The patient states she's a klutz. The patient's advised to go to the ER by ambulance. The patient states she wants to go back to the event and feels fine. So this would be, once again, an AMA. This would not be a release on scene. This would be an AMA. Although the patient was treated, she did not take the advice of the medical staff to go to the ER. What forms need to be filled out? You got it, an AMA and a PCR. And what should be documented? The fact that treatments were performed, the patient was advised to go to the ER, and the patient signed out AMA. And then lastly, we have a 32-year-old female who presents to first aid complaining of a headache. The patient states that she's been outside working in the weather that's about 96 degrees. The patient stated that she has very little to drink today and doesn't remember the last time she urinated. The patient's given water to drink. Her headache goes away. She's used the restroom. Her urine color improves. The patient states that she will go home and follow up with a primary care physician later that day. The patient was advised to keep drinking water. So what would you think? AMA or release on scene? Honestly, you go either way. You could AMA this one, or you could release it on scene. For this discussion, we'll release it on scene because, one, the patient has a minor complaint. She received treatment. Nothing was refused, and everybody concurs that she can go home and follow up with her physician. And is there any additional paperwork? Not really. Just we need to go ahead and complete the patient care report like normal, and then but no other forms that we need to go ahead and complete. And then what should be documented on the narrative portion of the PCR, basically any treatments we performed, and the patient will seek follow-up with her primary care physician. All right, moving down our call disposition list, we have EMS units blank arrived on scene and the patient signed AMA. So this occurs when you are working an event and an outside EMS agency is called to assist. Patient care is transferred, patient care is transferred, and they AMA the patient. For example, sometimes we have times where patients request ambulance transport, but then they change their mind once the ambulance service gets there. So we want to go ahead and make sure that we document all arriving EMS agencies and their unit numbers on that blank line. Then we have that the patient was taken to the hospital. So when patient transported by blank to blank hospital, this would be transported by the ambulance service and their unit number to whatever hospital they went to. So just a note on unit numbers, all incoming resources have individual unit numbers, aka call signs, that are assigned to them. This number must be obtained for documentation purposes. For example, the fire department has numbers that dictate what kind of resource it is. For example, they might be rescue or R, T or truck, E or engine, and then there's other resources that are also out there. And there's also a number assigned to that resource. For example, Rescue 10 would be the rescue that belongs to Station 10. Engine 218 would be the second fire engine that belongs at Station 18. And Rescue 301 is the third rescue that belongs at Station 1. It's very easy to get a unit number. Basically, you just walk up to the crew and ask them, hey, guys, what's your unit number? They're usually very easy and very easygoing giving that information. They're asked it numerous times a day, so they're used to being asked that information. So make sure that when units arrive on scene, we go ahead and we get their unit number. Now, this is talking about unit numbers for the fire department. Private ambulance also has their unit numbers. For example, AMR, Medic West, Community Ambulance are all and Mercier are the private ambulance services in town. So, for example, A107 would be an AMR unit, M502 would be a Medic West unit, and C202 would be a community ambulance unit. Mercier is identified as Mercier 714 or 21. Once again, very easy to get the unit number from the crew. Just ask them. All right, and then we have as number 5 on our disposition list, patient transported to an on-site event clinic. This is where we are working with a physician or any other kind of practitioner, like nurse practitioner or PA, and we transport into that clinic. The patient's assessed. We want to go ahead, still fill out our patient care report, but document that we transported the patient to an on-site event clinic. And then lastly, we have an other disposition. This is going to be, if it doesn't meet one of the other 5 dispositions, then we can go ahead and write something. The most common one that we might see is somebody that is taken to jail by police. So police have us come down at an event, take a look at somebody, and they go, but he's fine, we're going to go and take him to jail. So we go ahead and we just document that the patient was taken to jail. Or if we do have a dead body, we may go ahead and transfer that care over to the coroner. So if any kind of transfer of care or any other kind of disposition takes place, we want to go ahead and list it here in the other category. All right, moving down the list. So we have just some basic demographic information that we need to gather from our patients. So last name would be the patient's last name. Patient's legal first name would be the patient's legal first name. Patient sex. This is going to be either check male, female, or other. In the event you have somebody that is either transgender or non-binary, and they give you something that would fall in the other category, you can go ahead and document it here. Date of birth. This would be the day, month, and year the patient was born, and then the patient's age is obviously the age of the patient. Sometimes you may have to estimate the age. That's fine. You can put an approximate or squiggly equal sign would also mean approximate. Then the address, city, state, zip would be the patient's primary mailing address and where they receive their mail. Primary phone would be what the primary phone that the patient uses. And then we also have a emergency contact name and phone number that can be listed on the patient care report as well. And then we have the patient's weight and height to document, and a social security number or driver's license to document if that information is readily available. Now, a note on the social security number is that this is only mandatory if we transport or if Guardian Elite Medical Services loads a patient into one of our ambulances and takes him to the hospital. We need that information to interface with the hospital. However, if we don't handle that transport, another agency does, it's not vital information, but you can go ahead and get it. Moving down the list, we have patient history. So this would be the patient's past medical history. Any medications that the patient takes may also include drug use, alcohol use, or tobacco use, and then any allergies that the patient may have. And then the chief complaint. So let's talk about chief complaint here. So the chief complaint is defined as the reason why EMS was called to the scene. Now, it's important to remember, this is not a diagnosis. This is simply why we were called and the complaint the patient is experiencing. Typically, the chief complaint is written in the patient's own words or the words of bystanders. For example, I am having chest pain. My wife is having a seizure. He is drunk. We just found him laying here. I cannot breathe. We notice one thing in common with all these. They all are in quotes and they're all in the patient's own words. Examples of bad chief complaints would include just simply diagnosing a heart attack or diagnosing an asthma or seizure or drunk. We see that these are not chief complaints, rather these are a specific diagnosis. We have a place to actually put what we think is going on in a different field. But for the chief complaint, it needs to be what the patient says or the reason why we are called to the scene. So just to recap, just some acceptable chief complaints. I'm having chest pain. My father drank a bottle of vodka and will not wake up. 50-year-old male, unresponsive, not breathing. My blood pressure is running high. Can you check it? Or I've been vomiting for 2 days. Some bad ones, chest pain, unresponsive, cardiac arrest. This space intentionally left blank, meaning you don't fill it out. A chief complaint is required on all patient care reports. And then put not feeling well. Now, if these were to be in the patient's quotes, that would be something else. But somebody's writing not feeling well or heart attack or chest pain would not be acceptable. Okay, below the chief complaint, we have vital signs. It's important that we take vital signs on all patients that have a patient care report filled out for them. So the time, this is the time that we took the vital signs. This needs to be in a 24-hour format. Blood pressure is the patient's recorded blood pressure. Heart rate is the patient's heart rate. Respiratory rate, patient's respiratory rate. SpO2 is what we got on our SpO2 reading. End-tidal carbon dioxide is what we got if we performed end-tidal CO2. It's important to remember this is only a paramedic vital sign and does not need to be used on every patient. It only needs to be used when the patient's clinical condition indicates its use. And then pain scale. This is the patient's level of pain or discomfort on a scale of 1 out of 10, 1 being no pain, 10 being the worst pain they've ever had. And then blood glucose is the patient's blood glucose reading. And then BI is going to be who took the vital signs. So this can be documented as the name of a person, initials of a person, employee number, EMS number. It can also be an agency name. For example, if Clark County Fire comes on scene and you use their vital signs, you can document CCFD. It's important that vital signs are taken on all patients that have a patient care report filled out, or that we document why vital signs were not filled out. All right, moving down below the vital signs. This is the clinical impression. So the clinical impression is not a diagnosis. Rather, it is what you think is going on with the patient. When we write the clinical impression, we want to use the term suspected, possible, or rule out. For example, someone's suffering from shortness of breath from an asthma attack. Their clinical impression could be written as a suspected asthma attack, or possible asthma attack, or rule out asthma attack. Somebody suffering from a broken right humerus, their clinical impression could be written as suspected right humerus fracture, or possible right upper arm break, or rule out right humerus fracture. Bad examples would simply be just listing a diagnosis. For example, asthma, seizure, arm fracture. We're not physicians, we're not practitioners. Our job is not necessarily to diagnose, so we need to go ahead and go with the I think idea of what is going on. For example, I think this is going on, and we do that by using the term suspected, possible, or rule out. Sometimes it may be hard to distinguish between 2 or more possible causes of a patient's problem, so we can actually use the versus terminology. For example, possible asthma versus COPD, or suspected brain bleed versus concussion, or rule out hypoglycemia versus alcohol ingestional error. We see here that we can put 2 or more things using the versus terminology. And remember, as pre-hospital providers, it is not our job to diagnose. Therefore, we have to document our clinical impression as suspected, possible, rule out, and try to include a few possible conditions from your differential diagnosis. We see on the acceptable category, rule out unstable angina, suspected left leg fracture secondary to fall, possible appendicitis versus ruptured abdominal pain. Rule out non-specific abdominal pain, possible concussion, suspected abrasions to the left hand, and a suspected laceration of the nose. And unacceptable would be chest pain, bad, stomach hurts, leaving it blank. Remember, we want to go ahead and fill out what we think it is. Hit head, or just simply good. We've had a lot of issues with people that write just good or bad or fine or patient walked away. No, our clinical impression should be what we think is going on with the patient. All right, treatments. So we have a few lines for treatments. This is going to be what we do for patients. So we see the time is going to be the time a treatment was performed. Number 2 is going to be any interventions that we do. For example, whether we give the patient oxygen, we defibrillate, we give medication, or other. We do have lines for medication, other, so we can go ahead and document those. Number 3 is going to be our dose and our route. So this would be the dose and route of the treatment performed. For example, if we give oxygen, we would go ahead and check the oxygen box, and then we would document the type of delivery device used in the dose and route. That would be like a nasal cannula, non-rebreather, or SVN, or bag valve mask, and then the flow rate itself. Defibrillation, BLS providers, you can just document an AED was used. And then for ALS providers, we would want to go ahead and document the defibrillation dose. And then medications, we want to make sure that we document the dosage given to the patient and the route given. And then response, we can go ahead and document how the patient responded to the treatment. Simply writing good, bad, plus, or negative is not acceptable. We want to go ahead and see specifically how the patient responded to that treatment. For example, if we gave albuterol, we could document a decrease in shortness of breath. And then we have by, this is going to be who performed the treatment. And then lastly, we have IV-IO access, which I see my numbers are off, so I apologize for that. But anyways, IV-IO access, this would be if we do start an IV or start an IO on somebody, we go ahead and check what we performed. If it was successful, check that it was successful. If it was not successful, leave it blank. The size would be whatever size catheter we use. The location would be where we place the catheter, and then by would be who established the IV-IO line. Remember, for by, you can use their specific name, P number, EMS number, or agency name. That's fine. And then we have our physical exam. The physical exam is going to represent any findings on the patient's body. This section should be consistent with the rest of our patient care report. So for example, if you write a chief complaint that relates to the leg, then the lower extremity section of the physical exam should be filled out. Whenever we do the physical exam, we want to make sure we're documenting any pertinent positives or negatives. Now, when we talk about pertinent positives or negatives, these are specific things that we would expect to see or not expect to see for a given clinical condition. For example, a patient experiencing a myocardial infarction would want to be assessed for chest pain, shortness of breath, nausea, vomiting, dizziness, headache, abdominal pain, and any pain or discomfort in the extremities. I'm sure there's more you could think of, like swelling in the extremities and other kind of pertinent positives or negatives. So we can go ahead and document using the plus or minus sign to indicate whether any of those are available. Correction, not available, if any is present. Plus or minus if any is present. Sorry, guys. So if we use that MI example from the previous slide, then we can see how we document the pertinent positives or negatives. You see I did use red ink in here just only to go ahead and point it out and show kind of what we're documenting. But you see here that you're able to document additional information that is not necessarily on the check boxes. So for example, the head, we see this patient had dizziness but didn't have a headache. We see under the chest that we have pain 6 out of 10 that had no change on palpation or inspiration. And then lung sounds, you see here that we have rales and then shortness of breath on exertion. Abdomen, we see no nausea, vomiting, diarrhea. And then lower extremities, you see that we added in that there was +2 pitting edema with a rash. It looks like I spelled pitting wrong. Once again, my apologies for the spelling of this slide. So this is going to be a exercise that I'm going to have you guys do. So go ahead and pause your screen, read the slide, and we'll go ahead and continue. So from that previous example, you see here that we were able to write in additional information and additional pertinent positives and negatives as it pertained to that call of a person rolling their golf cart. All right, so now we go ahead and we're to the back of the patient care report. And the back side of the patient care report is used to write a narrative. So a narrative is basically a description of what happened while taking care of a patient. The narrative should paint a clear picture of the patient and should provide a description of treatments rendered to the patient. So two common ways that we train people to document a narrative is going to be the SOAP method and the chart method. So this is entirely up to you and what you want to choose. Most people do use the SOAP method. So when we talk about SOAP, we see here that each letter means something different. So S stands for subjective. So subjective information is going to be anything the patient or bystander say. Objective is going to be anything that EMS finds. It can also include how the patient was found and physical exam findings. Not sure why there's a question mark on that. That should be a period. And then the assessment is going to be what we are assessing for. So it should be the same as our clinical impression on the front of the patient care report. And then a plan is a step-by-step description of all treatments and interventions performed on the patient. So here's an example. So you see here for this example, we have our subjective information. And you see that the subjective information usually starts with patient states according to the patient, per patient. So if we read this, so patient states that he's been having chest pain for about 30 minutes. Patient states he was lifting some heavy boxes onto a truck when the chest started to hurt. Patient rated his pain as a 7 out of 10 and described it as an elephant sitting on his chest. Patient says the pain is radiating down his left arm. Patient states patient states he had 2 prior episodes of this. Last episode was 3 years ago. Patient states he's been prescribed nitro but left it at home. So we see this is everything the patient says. And then our objective findings would be a 54-year-old male able to track and follow EMS crew. Patient appears to be in mild distress as evidenced by the patient clustering his chest, shallow respirations, and cool diaphoretic skin. On physical exam, patient was noted to have chest pain that did not change with inspiration or palpation. And then our assessment is what we think is going on. So we think he's having acute coronary syndrome. And then our plan is a step-by-step plan of what we did. So for this patient, you see that we put him on, we checked his ABCs, we assessed them, we put him on oxygen at 15 liters per minute by GEMS 1002. We took vital signs, we did a body exam, we notified transport via landline, we got an EKG, 12 lead, gave aspirin, gave some nitro, we did a secondary body exam which showed a decrease in chest pain, we got an IV, we gave morphine, a community ambulance arrived, and then we transferred care to community ambulance and they took the patient to St. Rose Sienna. A second example would be, let's do a cardiac arrest. So according to bystanders, the patient on scene went unresponsive. Bystanders state they do not know the patient. Per bystanders, CPR was initiated about 4 minutes prior to arrival of EMS. So we see that's all of our subjective information. Our objective information could be a 63-year-old male found unconscious, unresponsive, lying supine on the ground with CPR in progress. Our assessment would be what we think is going on, so cardiac arrest. And then you see the individual steps for what we did for that cardiac arrest, when patient care is transferred, and where transport went to. And then we have the chart example. So for chart, we have chief complaint, which is the reason why EMS was called. This could be anything the patient or bystanders say. We have H, which would be the history of present illness, so basically a brief description of the events leading up to the chief complaint. Assessment, this is what we are assessing for. This should be similar to our clinical impression. RX, this stands for treatment. So this should be a list of all treatments and interventions performed on the patient. And then transport, this would be what happened to the patient after they left our care. So did they go to the hospital or were they AMA'd? So here's a chart example. So you see the chief complaint is in the patient's own words. So my chest hurts. History of present illness would be the H. So patient states that he was lifting some heavy boxes onto a truck when his chest started to hurt. Patient rated his pain as a 7 out of 10 and described it as an elephant sitting on his chest. Patient says the pain is radiating down his left arm. Patient states that he's had 2 prior episodes of this. The last episode was 3 years ago. Patient states he has been prescribed nitroglycerin but left it at home. A is rule out unstable angina, and then RX would be our treatments. So you see a list of everything that we did, similar to our plan for our SOAP method, and then T would be transport, so what happened to the patient after they left our care. Here's another example that we have. So we see here, C, per bystanders, patient went unresponsive, they started CPR. H, bystanders don't know the patient. They started CPR about 4 minutes prior to arrival of EMS. A would be what we think is going on, so without cardiac arrest. Our treatments would be everything that we do, and then our transport would be where the patient got taken to or what happened to them after they left our care. Now, some people, including myself, actually prefer not to use the chart method or the SOAP method. In fact, we prefer a blended method or narrative method. So this is basically a third way to document your clinical course or your narrative, and it basically combines your elements of your different elements of SOAP and chart into kind of one big kind of paragraph. However, if you do use the narrative method, just make sure that the following questions are answered. So how the patient was found, anything the patient said, anything bystander stated, any findings by EMS, interventions that were performed on the patient, and where the patient was transported to. So regardless of what kind of method you use, all these questions should be answered. We see here, this is an example of the narrative method where basically everything's kind of blends together. There's really no delineation between objective and subjective information. It's just all in one big paragraph and then a paragraph at the bottom that outlines exactly what we did. Once again, basically our subjective, objective information combined in a paragraph at the very end. Now, on the very bottom of the patient care report, we have signatures and attachments. So this is going to be whoever filled out the patient care report needs to go ahead and place their name on the bottom of the patient care report, and they need to sign it. And then attendant 1 is whoever signed, or whoever the first attendant is, and whoever signed the patient care report. The attendant 2 number is the employee number of the second person on scene. And then other could be other people on scene. So if we have additional employees, we can list them. We can list SNHD EMS numbers, or we can go ahead and document company names if they're on scene, for example, LVMPD, AMR, CCFD, or security. And at the bottom, we have a list for attachments. So if you do get anything like an AMA, or you have an addendum, or you do an EKG, or any kind of other attachment, go ahead and list it with the patient care report. And then lastly, we have our patient care report addendums. These are in the event that you need additional space to complete your patient care report. It's basically less information that you find on the patient care report, because we've already filled one of these out, and then we're able to expand upon or list additional stuff that didn't fit or wasn't included on the patient care report. So this takes us to the end of our video on patient care reports. If you do have any questions, please make sure that you call the on-duty supervisor, and we can go ahead and take care of those.